Please tell me, Please advise Liam if I'm coming in now.
1.5 minutes. we will start at 11 sharp in Jakarta.
Liam, give me a thumbs up if you'll start.
Okay, in 5. Okay. Yeah, you can start, Chinky.
Welcome to the third MINOSH International Conference, which is held in conjunction with the Joint Annual Scientific Health Conference of Uganda, Kampala, the 28th UNACOH Conference, and the 20th Dr. Matthew Lukwia Memorial Lecture from September 21 to 2023 in Kampala, Uganda for the physical conference and through virtual platform at this time. Our MINOSH special session runs today, September 22, 2022 from 7 o'clock a.m. Uganda time to 6 o'clock p.m. Uganda time. MINOSH, or Mining Occupational Safety and Health, is a scientific committee of the International Commission on Occupational Health. ICO is a non-government organization that is recognized by the United Nations and is the oldest organization in the field, founded in 1906. ICO also has a close working relationship with the World Health Organization and the International Labor Organization. The main organizers in this conference are MINOSH ICO, of which I am the chair for the triennium 2022 to 2024, the Makerere University, led by Dr. David Meya, the main organizing committee, and UNACOH, or the Uganda Association of Community of Occupational Health, led by its executive director, Dr. Deo Sekimpi. MINOSH goals and activities are focused mainly on promoting occupational safety and health in mining through research and advocacy at both the national and international levels, including the conduct of webinars and conferences for the coming together of experts and stakeholders. To open our virtual program, we have Dr. Professor Mukhtaruddin Mansour. Dr. Mansour is currently the secretary of MINOSH. He is also the chair of the Indonesian College of Occupational Medicine. He is a professor of community, occupational, and family medicine at Universitas Indonesia, a medical practitioner and academician dedicated in promoting occupational health and safety of workers, including miners. Professor Mansour.
Well, thank you very much, Dr. Cindy Leland, for the very kind introduction for me. Very good morning, everyone. Distinguished Dr. Cindy Leland as Chair of Miners, Dr. Ria Fajardo, the President of the Association of Occupational Health, the Philippines, speakers, session chair and co-chair, and all participants. Again, very good morning. from Manila and Jakarta. Good day for everyone. In additional what Dr. Jinky mentioned, Minus encourages networking and meeting of various stakeholders to promote ideas and share knowledge and experiences about workers and workplace health and safety promotion with life. It covers a wide array of groups in both large and small scale mining, formal and informal sectors, as well as the most vulnerable groups, such as the small scale miners, women, and children involved or affected by mining. So that's why we are happy that today the third miners international conference is in conjunction with the 16th Joint Annual Scientific Health Conference and 28th UNACOH Conference. Ladies and gentlemen, for not overdue, I am officially, on behalf of my scientific committee, officially open the third minor international conference. And we will have the valuable speakers, including for the plenary, Dr. Jinky Leland, a professor of research from National Institute of Health, Philippines. Jinky Leland is the current chair of the Mining, Occupational Safety and Health, as I mentioned before, a scientific committee of the International Committee on Occupational Health. She is a research professor at the National Institute of Health, University of the Philippines, Manila, and is a recipient of big funded research grants, including developing resilient health and environmental systems for the vulnerable environment and small-scale mining areas in the Philippines. She has produced more than 50 journal articles, all of which are science-based in injection, thus earning her the title of University Scientist from 2007 to present. He also authored two books. First, Gender, Information Technology and Health, which won the National Academy of Science and Technology Book Award in 2010, and reprinted by University of Hawaii Press in 2007, and the Basics of Occupational and Safety, guidebook for practitioners and industry, published by UP Press. He also contributes chapters in several books, and Jinky is a sound advocate, both as engaged academic and scientist in promoting the well-being of vulnerable and high-risk working populations such as the minor. Well, that is the valuable speaker for the preliminary we have. And please, Jinky, to deliver your speech. Thank you very much.
Good morning, good day, good evening, wherever you are in the globe. Thank you for that gracious introduction. Today, I am pleased to give the keynote talk in this conference entitled Evidence-Based Researches on Occupational Environmental Health in Mining, the Philippines and Other Country Experiences. I declare no conflict of interest. Mining has always been an integral industry and today remains an important industrial sector. According to the International Labor Organization 2022, the economies of scale usually limit the production of high-value industrial minerals such as gold, copper, and iron to highly mechanized, large-scale mining operations. However, in countries where domestic demand exists, these minerals are often mined on a small-scale operation. I will discuss some occupational and environmental health concerns in large-scale mines in this talk, but I will primarily focus on small-scale mining, or SSM. In the Philippines, mining and quarrying employs about 197,000 individuals, or 0.5% of the working population. Of these, large-scale employs only 37%, while 67% are employed in small-scale mining. Small-scale mining also remains to be one of the most hazardous occupations in many countries, with many cases of deaths, injuries, and diseases. Although only accounting for 1% of the global workforce, SSM is responsible for about 8% of fatal accidents at work. In developing countries, it generates a workplace fatality rate up to 90 times higher than in mines in industrialized countries. Accident rates as well in small-scale mines are routinely 6 or 7 times higher than in larger operations. A special problem also arises in the employment of children and women. What is small-scale mining? What are the some common features in this industry or sector? Minimal to no mechanization, often run in the informal or illegal sector of the market, use of rudimentary techniques, and lack of skilled workforce. It is also globally infamous for using mercury and cyanide because of lack of occupational health and safety safeguards. A commonly used chemical in mining is mercury. Mercury is a toxic chemical and is a global concern. That is why the Minamata Convention was drafted and ratified by signatory countries to prevent adverse health outcomes from mercury exposure. Small-scale mining is the largest source of releases of mercury into the environment, according to the International Labour Organization and the IISD, as you can see in this slide. The darker colored regions in this map shows the countries with the highest mercury emissions, red as the most concerning. China in red color has the highest mercury emissions at about 500,000 kilograms annually. In the second tier, orange color, belongs Brazil, Peru, Indonesia, and India. The yellow-colored regions are in the third tier. Philippines belongs to this tier, where its annual mercury emissions into the environment is estimated to be 32,000 kilograms. Alongside in this tier are Russia, Sudan, Ghana, Colombia, Venezuela, as well as the United States of America. In general, SSM contributes to more than 30% of the total mercury emissions globally, and that is concerning. It is also interesting to note that estimates of mercury consumption is the best available surrogate measure for the prevalence of small-scale gold mining, according to Perry Gottesfeld et al. Highlighted countries such as China, Indonesia, including the Philippines in the table, are classified as high-burden PTB countries by World Health Organization, and it is also here where the most prevalent mining operations are located. Due to this large mercury consumption and emissions in mining, the Minamata Convention was drafted and ratified by signatory countries with the key objective to protect the human health and the environment. This convention has 128 signatories. 91 parties have approved, ratified, and acceded the resolution, and the Philippines is a signatory to this convention. Why is the Minamata Treaty on Mercury significant? Because of the impact of mercury emissions and contamination on first human health, then we have the fetus, the children, and pregnant women, as vulnerable populations, the impact on water systems, such as our groundwater, rivers and creeks, biota, fishes, and aquatic resources, the air and the soil, as well as the impact on comorbidities with other diseases. Now, I will proceed to present researches on the effect of mercury on human health and the environment. First is a study on the impact of mercury on fishes in the study by Maramba et al. In the Philippines. Marine samples were collected near abandoned mines and measured for total mercury. The total mercury levels in fish collected in 3 communities range from 1.65 nanogram per gram of fish to 1,152 nanogram per gram. The 1,000 plus reading in fish is way above the US FDA standard level at 500 nanograms per gram of fish. Methyl mercury levels in fish near the abandoned mines also range from 1.29 to 931 nanograms per gram. This reading is way above the Japan standards for methyl mercury in fishes at 400 nanograms per gram. In all the study areas in this study, the total and methyl mercury in fishes were significantly higher in abandoned mine communities than in the control sites. In the same study, mercury and methyl mercury were also measured in biologic samples of the hair and the blood in 4 vulnerable groups of population: the infants, the children, the mothers, and the pregnant women. The results showed the following. First, methyl mercury in hair levels of exposed infants was significantly higher than in the control group. Second, methyl mercury in the hair of pregnant women and mothers was significantly higher as well in the exposed group than the control group. This shows that there is absorbed dose of both total mercury and methyl mercury among vulnerable groups of infants, children, mothers, and pregnant women in communities where abandoned mines are located. In another study in Tagum, Philippines, in the southern part of the country, water and sediment samples were analyzed for mercury contamination. This is a study by Akagi et al. In gold refining plants. Levels of total mercury for all water samples and sediments in the study exceeded the national and international limits. Specifically, all 7 water samples exceeded the limit, and all 27 sediment samples also exceeded the reference limit. In the same study, 163 children aged 5 to 17 years old were also assessed blood and hair samples. Results showed that 6.13% of the children had elevated total mercury blood levels, and about 3% had elevated hair mercury levels. On physical examination, abnormalities were found in all 163 children with the following 5 predominant abnormalities: under height, underweight, adenopathy, and dermatologic abnormalities. Fish is a regular dietary intake of the children, and since the fishes have high mercury levels, it is not surprising that the hair and blood samples from these children are also above the reference limit. Now we look at mercury contamination in sediments in a major river system in the Philippines, Mandulog River by Buot et al. In the southern part of the country. As you can see in the map, there is increasing mercury contamination in the sediments of the river, showing the effects of mining wastes being flushed to the river. It is observed that the highest concentration of mercury was 42.45 microgram per kilogram at the mouth of the river to the sea. In another study, still in the Philippines by Giron et al., mercury contamination was analyzed in rice cultivated in small-scale mining areas. The study looked at mercury levels in contaminated rice fields for both soil and rice grains using a case control design. It is disturbing to note that the processed rice grains or grains without hull that we eat showed a higher mercury level indicating bioaccumulation. In a remote sensing study in the Philippines by Ang et al., specifically DDPO northeast of Manila, a socio-environmental land cover time series analysis of mining landscapes using Google Earth Engine and web-based mapping was done. The study showed that, as you can see in these maps, there is a 41% decrease in the primary vegetation from the year 1994 to the year 2018. This is indicative of habitat and biodiversity lost. For health assessment, a meta-analysis on studies from 5 countries, Philippines, Mongolia, Tanzania, Zimbabwe, and Indonesia, was done by O'Reilly et al., which showed interesting results. Both miners and the community at large from various small-scale gold mining areas were examined. There was a total of 1,252 respondents in the study, 232 from the Philippines, 196 from Mongolia, 218 from Tanzania, 193 and 123 from Zimbabwe, and 168 and 122 from Indonesia. There are several biomarkers used in this meta-analysis, including urine, blood, and hair samples measured for both organic and inorganic mercury. For urine as a good biomarker for chronic inorganic exposure, the highest maximum mercury urine levels were also found in Indonesia, 5,240 microgram per liter, and Zimbabwe at 1,530 microgram per liter, way above the reference level, which is only 25 microgram per liter. Mercury in urine was corrected for creatinine as a marker for acute exposure. The highest maximum mercury levels were found in Indonesia as well as in Zimbabwe, with readings of 1,697 microgram per gram and 547 microgram per gram, respectively, which are above the reference level set at only 17.7 microgram per gram. The study also looked at mercury in blood, as this indicates acute and chronic exposure for both inorganic and organic mercury. The highest maximum blood levels were found in Indonesia at 429 microgram per liter, way above the reference level, which is only 200 microgram per liter. Then, mercury in hair was also used as a marker for chronic organic and inorganic exposure. The mercury in hair showed the following results. The highest maximum mercury hair levels were found in Indonesia at 792 microgram per gram. Among the exposed groups in these countries using meta-analysis, the most common health problems were ataxia, abnormal mental labial reflex, among others. There was a significant difference between exposed and control groups for most of the health symptoms. In the Philippines, we also conducted health assessment in our study among small-scale miners in Benguet, Philippines, located in the northern part of the country, which hosts several small-scale and large-scale mining operations. In a study of ours among 98 female small-scale miners, we did a factor analysis for the health symptoms to see the grouping of diseases. As you can see here, The female miners were shown to have lifestyle diseases such as hypertension, diabetes, and kidney diseases, which are highly correlated to the first component, lifestyle diseases. Thyroid disease and cancers are highly correlated to the second component, endocrine system affectation. Heart disease and tuberculosis are correlated to the third component, the dust exposure illnesses. And allergies and digestive problems are related to another component referring to diet-related illnesses. We also conducted an environmental study on mercury and cyanide monitoring in water samples in Benguet, again in the northern part of the Philippines. All 13 communities of the province in the target site were included in the study. These communities are shown in the figure and were measured for water quality for mercury and cyanide. The pin shows the location of the water sampling done in our study. 40 samples were taken from drinking water and 90 samples from surface water, including rivers, creeks, and streams. The results of the study show the following. The average mercury concentration of all the drinking water samples was 0.08 microgram per liter. This exceeded the water quality guideline of the Philippine Department of Environment and Natural Resources at 0.001 microgram per liter. For surface water, the average mercury contamination of all the samples was 0.1 milligram per liter, as you can see in the graph, and again exceeded the USEPA reference level of 0.002 milligram per liter. On the other hand, the mean cyanide concentration of all the drinking water samples was 0.005 microgram per liter, and this is within the reference level of 0.07 milligram per liter. For surface water, the mean cyanide concentration was 0.005 milligram per liter again, which is also within the reference value of 0.1 milligram per liter. And why is this? Because cyanide readily evaporates into the environment and does not remain in soil and water for a protracted time. Suffice to say that there is cyanide reading in the water samples, including the drinking water. To summarize, we found that 85% of the drinking water samples with mercury levels exceeded the reference value. 91% of the surface water samples with mercury levels exceeded the reference value as well. On the other hand, there was a total of only 2% of the drinking water samples that exceeded the guideline for cyanide in drinking water. Again, because cyanide readily evaporates into the environment. In a study of Lyon, my research advisee in a research project, laboratory assessment was done among 93 male small-scale miners in a community in Benguet. As you can see in the table, large proportion of the miners showed abnormal test results in their hemoglobin, reticulocyte count, and AST levels, all at 26.7% or more than a quarter. It is surprising that 14.71% or about 15% of all the male small-scale miners had levels of cyanide in their blood above the reference value. Imagine having cyanide levels in your blood. In the study, 15% of the miners had elevated cyanide level in their blood, as mentioned earlier, and this was significantly associated with respiratory problems and genitourinary symptoms. 26.5% had elevated reticulocyte count, and this was significantly associated in our study to total lifetime mining hours. 17.7% also had elevated serum creatinine, and this was associated with chronic exposure to cyanide in mining. Complete health assessment was done, including cognitive status examination. The cognitive status examination is a measure that covers areas of cognition such as orientation, calculation, memory, and language, among others. The maximum score is 30, and a score of 23 or below is indicative of cognitive impairment. As shown in the red boxes, 82.4% showed abnormal mental status scores. Specifically, most minors showed low test results in repeat phrase abilities at 97.1%, recent memory at 67.6%, and calculation and orientation both at 23.5%. This finding is similar to a study wherein long-term cyanide toxicity was found to cause cognition deficits. To complement these studies in the Philippines, I would like to share an interesting study on Geographic Information System, or GIS, and health effect in mining using geospatial images. In a study in Spain, towns situated at a distance of 5 kilometers or less from mining installations registered statistically significant increase in the risk of dying from various types of cancers. This table shows us the risk ratios. Those who live near the mining installations have 10% increased risk in dying from colorectal cancer, 7% increased risk in dying from lung cancer, 2% increased risk in dying from blood cancer, and 9% increased risk in dying from leukemia. Despite limitations mentioned in the study, this shows association between point source environmental pollution and various types of cancers in the context of mining. In summary, evidence-based studies on occupational and environmental risk, which I have presented in this talk, in the mining industry, both small and large scale, in the Philippines as well as in other countries, show the following. Mercury levels are above concentration reference values. Cyanide levels can be a potential risk. Mercury levels were found in various studies in the Philippines to be above reference level in various environmental media such as soil, water, the river, sediments, drinking water, surface water, and including fishes and aquatic resources. Health symptoms and abnormal laboratory findings, including cognitive deficits, were also noted among miners, and there were also health injuries and fatalities. All these show the multifarious occupational and environmental health impacts of mining in general and chemical exposures brought about by mining in particular. Cognizant of the environmental and occupational health issues in mining, specifically in a small scale, but not ignoring actually the fact that exports of high-value metals and minerals from small scale make a major contribution to foreign exchange earnings, and at the household level, there is a need for renewed and strong policies covering four areas. First, the regulation of small-scale mining. Second, the strengthening of institutional capacities. Third, establishing occupational and environmental monitoring and surveillance systems. And fourth, the implementation of the mercury-free gold mining, a significant goal of the Minamata Convention, which is one of the major topics in this MINOSH International Conference. To address the call of the Minamata Convention, among others, our organization, the International Commission on Occupational Health, together with our scientific committee, Mining Occupational Safety and Health, have advocated occupational safety and health in mining both at national and international levels. A concrete story of ICO and Minosh and partners is the inclusion of occupational safety and health in the TB Declaration at the United General Assembly in September 2018. In the UN Political Declaration on TB, our policy statements have been adopted and included by the United Nations, specifically paragraph 17, identifying, quote, healthcare workers, minors, and other exposed to silica as high-risk vulnerable groups. And paragraph 31, which commits signatories to, quote, implementing primary prevention in high-risk occupations by reducing silica dust exposures in mining, construction, and other dusty workplaces. I would like to end by thanking all of you in this conference. Yes, we are all invested to be gathered together today because we believe that through our mutual passion for advocating for occupational health and safety in mining, we can achieve the rights to decent work and the national and global health care for all. Thank you very much. Maraming salamat. Mabuhay. Good morning. Okay, so now let us proceed to our oral presenters in this virtual platform. Our first speaker is Dr. Nguyen Thi Hoya Nga from Vietnam. Dr. Nga has been working at Hanoi University of Mining and Geology in Vietnam since 2001. In 2013, she achieved her doctoral title at Aachen, Germany. She gains experience in occupational safety and health from doing research in the coal mining industry of Germany and Vietnam and lecturing in both universities and the industry. Dr. Nga is an active member of ISA Mining since 2013. And since 2020, she became the vice president of the organization. To talk on Vision Zero, tools for safety, health and well-being management, and the application to the Vietnamese coal mining industry, Dr. Nga Nguyen.
Thank you, Dr. Lu, and thank you all for giving us such a very nice opportunity to present about the Vietnamese experience in the coal mining industry. So how we implement the 7 golden rules in Vietnam so far, and in especially in the last few years, I was concentrating on the underground coal mine and apply the 7 golden rules, and I appreciate this opportunity a lot. So I would like to introduce to you the context of Vietnam and the very brief information of the 7 golden rules, as well as what we have been done so far. Finally, some lesson learned. So Vietnam is located in the Southeast Asia with a population of over 100 million people. We are endorsed with more than 5,000 mines and mineral deposit with coal, apatite, copper, iron, and tungsten. Also, in the south of Vietnam, we are very have a high reserves of limestone and other construction materials, as well as oil and gas. Investment in the mining industry takes roughly 5 to 7% of the total national investment, and mining is also one of the biggest employers in the nation. Regarding the direct workers in the mining industry, both in private and public sector, or FDI, but also for the induced employment. And the mining companies in Vietnam especially in the private sector, especially in the public sector, and the FDI often list in top 1,000 income taxpayer. So in the last few years, the contribution of the mining industry is not so high as in the past, roughly 7% of the GDP. It is not only it's not because the mining industry narrows the scale, but the development of other economic sector in Vietnam, and you might remember that Vietnam is now ranked the 40s in the GDP list out of almost 200 countries. And to the social economy, the mining industry offer working places for many employees, as I mentioned before, even the unskillful one working in the SME mining company, and provide also infrastructure to the community, especially in the remote areas, and support with both financial and non-financial for the corporate in the corporate social responsibilities program. However, we are facing with negative impacts regarding safety and occupational safety and health. Although the situation is much better during the last 10 years, with different level of the action from the ministry, from the state, the ministry, the principal authorities, and also in the mining companies. Mining is less attractive to the skillful laborers nowadays, and this is also one of the factors to the safety and health. However, in the mining industry as well as the construction industry, there is also the high ratio of fatalities and fatal accidents. So the introduction of the 7 golden rules with the leadership, the choice for the good safe equipment, the motivation of the workers and engagement of the community, etc., have been introduced in Vietnam in 2012, so 10 years before, and in many activities like workshop and seminar and international conference. And now we introduce again and again the golden rules in with the top authorities, with the companies, in the universities. We integrate with the support from the TAO, teaching, academic and university committee in ESSR mining, so that we integrate also in the universities and college about Vision Zero and the 7 golden rules, and also in the companies. So we I haven't had a chance to brief about the 7 golden rules here, but if you search with the 7 golden rules, you can see also in internet many information regarding this rule. And one is take the leadership and demonstrate the commitment. This rule number 2 is identify the hazards and control risk. The rule number 3 is define the target and develop programs, safety programs. Rule 4 is ensure the safe and healthy system be well organized. Rule number 5 is ensure the safety and health in machine, equipment, and workplaces. Rule number 6 is improvement of qualification and development, being the competence. And rule number 7, which is not last but not less important, is invest in the people, motivate the participation. And with this idea of the 7 golden rules, I have been teaching in the college and universities for several years since 2018 till now, and recently recently I have just last week gave a lecture to the junior leaders of mining companies. So you can see in the pictures stated 2020, 2022. I also put the 7 golden rules into the introduction with the mining companies leaders, and imply also with the LACET 3 or 5 to evaluate how the mining companies in Vietnam implement the 7 golden rules, and the results you can see in the picture that I stated with 2020. This is a pilot program in the most modern coal mining companies in Vietnam. Later on, I also published the results of the implementation in international journal as well as the national one, and this also attracted the attention from the audience, and not only the leaders of the mining companies but also the public. In the beginning of 2022, the company in Vietnam who implement the 7 golden rules also adapt with composing the document to evaluate the safety categories of the company, and making the handbook for the workers based on the 7 golden rules, as well as other guidelines for the miners. And they also developed the 7 golden rules into the safety control regulation of the company. And as you can see in my hand, this is the 3 documents that are free delivered to the miners. And we also copy this model to other mines in Vietnam to improve the safety competence, safety control, and to improve the occupational safety and health in the companies. So some lessons learned from the implementation in Vietnam is we need the network from the trainers for the Vision Zero, and the promotion of the 7 golden rules, sharing the experience and the stories of the users, and not only in Vietnam but also in other countries in Southeast Asia, we can do the capacity building for safety experts and trainers with the engagement of ESSR mining. And I know that ESSR mining is, or ESSR is not only in Vietnam, but also in some Asian country like Indonesia, Philippines, and Malaysia, if I do not make a mistake. And but the list of the accredited trainers who can use the materials as well as have willing to share the experience and to teach, the number of the trainers are still limited. And in that case, universities in South Asia will play a very important role to develop the philosophy as well as to share the experience, and working together to improve the safety and health management in our countries. So I know that the time for me is not much. So, and I'm looking forward for further exchange from you after the presentation. So feel free to contact me and raise a question. Thank you very much for listening.
Thank you very much, Dr. Nga. Indeed, we need guidelines for our workers and stakeholders in promoting safety in the workplace. And thank you for that 7 golden rules for safety and health. Our next speaker is Dr. Alexander Alcantara, who is currently the director of the Legislative Committee of the National Board of the Philippine College of Occupational Medicine, in short, PCOM. He is the recipient of the Most Outstanding Occupational Physician of the Philippines in 2021, a professor, a researcher, and an active occupational physician in several institutions in Baguio and Benguet, Philippines. Everyone, Dr. Alexander Alcantara, to talk on evaluation of blood lead levels.
Thank you for this speaking invitation. A pleasant day to everyone. It is my pleasure to be part of this third international conference on mining occupational safety and health to benchmark and share our occupational safety practice in the Philippines, particularly in the mining industry. Lead toxicity has become a growing health concern in our country. The title of our research is Evaluation of Blood Lead Levels and Their Effects and on Hematological and Renal Function of a Specific Occupational Population in Benguet, Philippines. The objective of the study is to determine the occupational exposure to lead and examine the association of blood lead levels with hematological and kidney function parameters in mine workers. We are to answer some important problems. These problems are: what is the hematological profile of the exposed and unexposed mine worker? Second, is there a significant difference in the hematological profile of miners to the years of occupational lead exposure? And lastly, what is the correlation between lead exposure and creatinine levels of miners? Because of the lack in blood lead surveillance program in the country, specifically in the mining industry, this study will highlight the value of a regular assessment of blood lead cell morphology, kidney function, and blood lead levels. This will be beneficial in controlling harmful biological effect of lead exposure in workplaces. The background of the study: lead is a naturally occurring toxic metal found in the Earth's crust. Its widespread use has resulted in extensive environmental contamination, particularly in the human. Sources, particularly in food, sediments, soil, water, and dust in industries like paint industry, food processing industry, pesticides, and highlighted today would be in the mining industry. These deposits in dust, food, air, and water, entering the body through the following route: skin absorption, ingestion of food and water contaminated, respiration, and absorption also in maternal and fetal circulation, deposited in long bones, brain, liver, kidney, and also the blood that is able to pass through the blood-brain barrier. This slide would just give us the threshold in HMRC goal of less than 10 microgram per liter of lead, elevated of more than 10, notifiable levels of more than 15, dangerous elevated levels at 25, and symptomatic levels at 45. Lead concentration and its effect in the young individuals and adults would have a spectrum of mild to severe, 10 starting with hypertension, and 50 with starting neurologic signs, and more than 100 with nervous toxicity. Let me walk you through the biological effects of lead in the human body. Lead poisoning can occur when lead builds up within the body, usually over a period of time. This excessive amount of lead in the body can cause serious health problems. Particularly, young individuals are vulnerable to lead poisoning, and it can affect their physical and mental development. It is a medical condition caused by increased levels of lead within the body that interferes with the normal processes of the body and particularly of the young. Why does this happen? Lead and calcium competes for the protein that is important for body to function well. Lead can displace the calcium from the protein, so the calcium will not be able to function properly. How can we simplify the signs and symptoms of lead poisoning? So the word lead, L, for lines in the gingiva and long bones. E for encephalopathy and erythrocyte basophilic stippling. A for abdominal colic and anemia, and D for nervous effect, namely on drop foot and drop wrist. How does this happen? Lead inhibits the enzyme that are needed to make heme. Heme carries oxygen. So it competes with the oxygen molecule, having a low oxygen level on the blood itself. The red blood cells will retain aggregates of RNA that causes stippling of the cell. And this would become a problem. The summary of the background. Lead is a trace element seen in industries to include mining. Blood lead threshold at less than 10. Toxicity levels notifiable at 15. Dangerous at 25. Symptomatic at 45. The word LED would give us systemic effects. Prevention and control, namely on engineering, administrative, and PPE, and treatment and recommendation would be included as chelation therapy. The study implemented an analytical approach, namely a case control study comparing the exposed and non-exposed miners. This included 100 mine employees of a certain gold mine complex in Itogon, Benguet during their annual physical exam in 2021 and 2022. A computation of the sample size was done to determine a good confidence interval used in the statistics. A duly licensed medical laboratory was contracted for the specimen collection, biochemical testing, hematological testing, lead concentration in the blood, and urine creatinine determination. A data collection of SPSS version 19 was implemented, and a test to determine linear relationship and level of significance was included. It included all male workers in the assay department and excluded those who were working less than 1 year, all those with second jobs, and those with inherited hematological renal infectious, allergy, rheumatic, diabetic, hypertensive, and with mental disorders. Set also to control the following confounders: age, weight, employment, duration, cigarette smoking, alcohol intake, and average daily exposure to lead. We have the following results. The first table, complete blood count and their exposed and unexposed group. The table would give us these findings: higher levels in the exposed groups with regards to WBC, RBC, MPV, eosinophil, and monocyte, and lower level with regards to hemoglobin and hematocrit and other parameters. This is consistent with the findings of Mohamayan in 2019, Qualba in 2018, and Nanghong in 2017. All would have the same result of higher levels of WBC but lower levels of hemoglobin that is associated with anemia. Table 2 would show changes in complete blood counts compared with the years of exposure. Tables would give us this relationship. The significant relationship between the years of exposure to lead would be higher in MCV, MCH, and platelet, would also have a linear increase both in the eosinophilic count. This is supported by the study of Aminian in 2019 and the Center of Disease Control Studies in 2018. Table 3 would show us the changes in blood synthesis and renal function biomarkers with lead levels and duration of occupational exposure to lead after controlling of confounders, whereby we would see an increase in both your blood creatinine and urine creatinine for those who are members of the exposed groups. In conclusion to the study, chronic occupational exposure to lead decreases hematocrit, RDW, MCV, MCH, and hemoglobin values. Another conclusion, The results showed a linear and significant relationship between blood lead, urine creatinine, and blood creatinine with regards to the years of exposure. The results showed also a linear and significant relationship between blood lead levels, urine levels to the exposed groups. What were the limitations of the study? Lack in the measurement of lead in inhaled air of workers, lack in measurement of exposure to other heavy metals, limited number of included workers due to the high cost of blood lead testing. That is the last slide. Thank you very much for your kind attention.
Jinky, you are muted.
Okay. So thank you very much, Dr. Alex Alcantara, for showing us the effect of of lead exposure to the hematological and renal function of the mine workers in Benguet. So our mine workers are not only exposed to cyanide and mercury, but to lead as well. Our next speaker is Dr. Karen Rimando, and she is currently working as company occupational health physician in one of the largest gold mining company in the Philippines, the Philex Mining Corporation in Benguet since 2008. She has been a member of the Philippine Medical Association, Baguio Benguet Medical Society, and Philippine College of Occupational Medicine, Baguio Benguet Chapter. She was also conferred as diplomate of the College of Occupational Medicine in 2016. Let us all welcome Dr. Karen to discuss managing sickness absenteeism and policies on medical examination in the mining occupational safety and health in the Philippines.
Thank you, Dr. Lu. So good day, my dear colleagues. So I'm here to discuss to you managing sickness absenteeism and policy on medical examination in the Philippines. So just a backgrounder, the Philippines has a total land area of 30 million hectares. 9 million hectares has a high mineral potential, and only 727,372 is the total land area covered by the mining tenements. That is as of May of 2020. With regards to employment, earlier with Dr. Lu's lecture, she mentioned that the Philippines has already employed 197 workers in the mining industry. So I would like to correct myself with that. She has the latest data on it. And it is also said that during the pandemic, there was increase in the employment of the mining industry. That is most probably due to the early response of the mining companies in effectively mitigating the risk of COVID infection. Mining companies in Benguet were also able to secure the jobs of their employees. The Department of Environment and Natural Resources Administrative Order number 2000-98, or the Mine Safety and Health Standards, have mandated the Mine and Geosciences Bureau to enforce health and safety in mining, exploration, mineral processing, and also quarrying in the mining industry. So just an overview, as per the International Labor Organization and the World Health Organization, occupational health is the promotion and maintenance of the highest degree of physical, mental, social well-being of all workers in all occupation. Absence culture is said to be the pattern of sanctioned, condoned, and unaccepted non-attendance in a particular organization, which is influenced by several factors. Sickness absence is also a process caused by a perceived incapacity for work as a result of disturbance in the social and physical functioning of an employee. What are the reasons why people take some time off work? These are the following. It may be due to short-term or acute sickness absence, long-term or chronic sickness absence, unauthorized absences, for example, alcoholism, and also persistent tardiness. Other authorized absences may be due to paternity leaves, maternity leaves, or emergency leaves, for example, when a member of the family passes away. So there are also points to consider with absenteeism. We should take into consideration patient case treatment and management. There would also be possible work disruption due to sickness of a coworker. There could also be a decrease or limited productivity due to the illness. And of course, we also have to consider the return to work fitness program. These are the common sickness absences that were documented in the mining industry in the Philippines, particularly here in Benguet. So we have low back pains, the musculoskeletal syndromes, arthropathies, industrial cases or the injuries obtained at work, like contusions, lacerations, fractures. We also have the respiratory infections. This may be due to the classification of the mining industry as hazardous or a high-risk industry. So we also have the lifestyle diseases like hypertension and diabetes. So I believe that every company should have a sick leave policy in order to manage the increasing or the arising problems due to sickness absences. So there is no explicitly mandated vacation leave and sick leave by the Labor Code of the Philippines or the Department of Labor and Employment. It is upon the discretion of the company, or a day leave at least every 24 days or 15 days in a year. The Labor Code only requires service incentive leave, which is equivalent to 5 days in a year. If ever a worker requires an extended sickness absence and his company sick leaves are already consumed, he may file an extended leave through the Social Security system, which is given a maximum of 120 days, but is still pending evaluation. So what are the general rules for the policy? Employees unable to work because of legitimate illness or injury are required to seek medical consultation. And if deemed necessary, confinement of employees are done, or home visitations are also done by our occupational health nurses to monitor the status of the employee. Employees on sick leave shall be regularly subjected for medical evaluation by the company physician, and employees on sick leave who are referred or may seek consultation outside the company clinic or hospital and being evaluated by a specialist outside or requires a special diagnostic procedure outside, they must update the occupational health section at the earliest possible time. They should also provide the necessary documents like a medical certificate to the occupational health section for evaluation and clearance prior to returning to work. A return to work clearance is issued by the company physician once fitness evaluation is done, and that is in coordination with the Human Resource Department and the department concerned. In the company where I am affiliated, I guess we are fortunate enough to have a hospital inside the company. It's more of an infirmary, so medical services, we could readily provide the medical services needed by our employees. And we also cater to their dependents. By the way, we have an estimate of 1,900 employees. Included there are the contractors. We also cater to their dependents, the wives and the children, and also we cater to the members of the household of the host communities. So with our facility, we accommodate more or less around 8 to 10,000 patients. So we also have our policy on medical examination. Medical examination is conducted to all covered employees to evaluate health status and prevent ill health, screen for risk factors, early detection of treatable diseases, maintain their well-being, and provide preventive counseling and patient education. All regular employees and prospective employees are covered by the policy. We have several examinations done. So we have the pre-employment medical examination, which is done with the applicants to determine their health status prior to work engagement. The annual medical examination is offered to regular employees to assess their health and current physical state, follow up previous findings, and also allow early detection of occupational and non-occupational diseases. Transfer medical examination is done for employees assigned or applying for a job transfer to assess if he is physically fit for the vacant position. The return to work medical exam is done to an employee who has undergone sickness absence and would be evaluated prior to clearance to return to work. Exit medical examination is for employees who either through resignation or retirement to assess their status prior to separation from the company. So after the evaluation of these employees, we also give them the fitness rating. Class A being physically fit, Class B with physically underdeveloped or correctable defects, Class C are employable, but owing to certain impairments or conditions require special placements and might require follow-up treatment and periodic evaluation. Class D is unfit or unsafe for any type of work. So these are the laboratory tests available in our facilities. And if after the evaluation, the employee requires a special test or needed to be referred outside in a special laboratory, we give them the requests. So I would just like to share to you the other health programs available in our company. So we have the hepatitis B prevention and control, mental health and well-being policy, HIV and AIDS prevention and control, drug-free workplace, anti-sexual harassment, the TB prevention and control, ergonomic program, workplace health promotion program, hearing conservation program, and of course, we also have the first aid policy. This is so because in coordination with the safety department, we conduct regular training for the employees to be first aiders because we want that if there are any cases or injuries at work, they would be the patients would be assessed or given treatment immediately before they are transferred to our facility for further management. So I guess that's all about my topic, and thank you for listening.
Mhm. Thank you, Dr. Karen, for showing us the importance of monitoring sickness absenteeism, which has implications to productivity as well as the macroeconomics of a country. Okay, so let's proceed to our next speaker, Dr. Leopoldo Kalimlim. He is a diplomate and fellow at the Philippine College of Occupational Medicine. He will discuss employees' compensation, the beginning and the end of the mining occupational safety and health today. He took his Master of Occupational Health at the University of the Philippines, Manila, and he is also the founding chair of Occupational Health and Industrial Medicine Department at the Notre Dame de Chartres Hospital in Baguio City, Philippines. Leopoldo Kalimlim.
Hello, good day, everyone. The employee's compensation, the beginning and end of the mine occupational safety and health today. If a simple management model is followed, planning, implementation, and evaluation, or PIE, can be it. Having said that, mine occupational safety and health necessarily begins in the planning phase, with an analysis of accidents, illness, and death in the mining environment, not only while sickness benefits and hospitalization and rehabilitation exist, compensation appears to have the heaviest burden. Whether temporary, partial, total, and overall, compensation is the biggest threat in the Philippine Compensation Fund. It is called the State Insurance Fund, managed by the Employees Compensation Commission. As of September 30, 2020, the status of the State Insurance Fund securely stands at 72 billion Philippine pesos or 1.44 billion US dollars. We believe in healthy worker for economic miracle, our corporate occupational health and safety slogan. Despite OHS measures, however, in case of occupational illness, accident, or death, it is but legal and moral to extend compensation for work-related occupational contingency for the worker and their family. Well, a brief history of employees' compensation in the Philippines at Baguio Benguet. The industrialization of Europe in 1850s made its way to the Philippine Islands through the United States. As early as 1909, the creation of Baguio as a resort city because of indigenous mining evidenced by the natives' implements of copper mined by themselves. Introduction of industrial mining stimulated and prospered in the area so that Baguio Benguet eventually became the mining capital of the Philippines. The logo of the city shows that there are 4 mining companies that started as early as 1903. Later, the bigger explorers, Lepanto Consolidated Mining Corporation, or LCMC, in 1930s, then Felix Mines in the 1950s, and we have a speaker from the company. The last 2 later opened, expanded to other islands, especially Mindanao. Surigau's Manila Mining and Silangan Mines of Lepanto and Felix respectively. Also of note is the establishment of Nickel Asia. Also in Mindanao under Gerard Brimo, former Felix Mines Chief Executive. The introduction of Employees Compensation Commission in 1975 under then Labor Minister Blas Ocle, under the presidency of the current president's father, mining companies became more conscious about mining occupational safety and health, thus stimulating effort to avoid or minimize industrial accident, occupational illness, and untimely death, thereby creating a compensation package for the benefit of involved miners and other workers and their families. Exploring deeper, not only into the bowels of the earth for gold, but into the inner psychic and emotional needs of incapacitated miners and their families, we unearthed their need to have a support group once they get separated from the mining company, either by disability, retrenchment, or by untimely death. Moving out, there were no houses and lots, no alternative livelihoods. Children in universities were not ready to be relocated. Not to mention the emotional pain of leaving their community and neighborhood for 30 to 40 years. We were fast to pick up their need, thus organized them into the Retired Mine Employees and Dependents Association of the Philippines. The regular meeting place was the Notre Dame de Chartres Hospital conference room. Here we help them verbalize their needs and aspirations, uncertainties, and financial challenges in the near term as well as long term. As a result, several concrete projects were made. Number 1, housing and subdivision project with livelihood. It was called the gold miner subdivision in Yagyagan to Babenguet. Second, regular General Assembly meetings and election of officers. Third, annual courtesy call and dialogue with the Department of Labor Regional Director on Labor Day, May 1st in the Philippines. Meetings and consultation to address issues encountered in their SSS and EC disability claims individually. And finally, annual Christmas party on Three Kings Day on the first week of January. International exposure in employees' compensation from the Department of Labor's attached agency, the Employees Compensation Commission, or the ECC Industrial Clinic Project for small to medium enterprises. It was initiated in 1996. The close to 25 ECCICs introduced with the social security system and employees' compensation itself as implementers, and in partnership with the private sector, 200 or less employees were reached with free annual medical examinations. This created awareness among SMEs who were more vulnerable with various hazards inherent in their specific industries. This opening of the country's occupational safety and health consciousness extended not only to SMEs, which composes more than half of the private employees, but also to the larger corporations and enterprises. This prepared our industrial clinic so that retirees from the United States, nearby Australia and New Zealand, started gaining access to the Philippine occupational medicine physicians in disability evaluation, assessment, and recommendation of retired workers and U.S. military personnel under their TRICARE program for claims in their respective countries in the U.S., Australia, and New Zealand. Finally, research collaboration with Japan through the former Japan International Center for Occupational Safety and Health, or JASH, was also established, starting with a course in physical agents as well as courses in pneumoconiosis, both in Tokyo and Kyoto, Japan. Collaboration continued on for years as both countries exchanged information in government policies, statistical data, and news development in both Philippines and Japan. It is with this training that prevention, diagnosis, and management and compensation of pneumoconiosis was recognized and therefore compensated by SSS and ECC pursuant to PD 626 as amended. Further elevation to the Court of Appeals were pursued in case application were denied by SSS and later by ECC. The birth of best practices in the Philippines, a COVID-19 response. Telemedicine at some point became the only way of reaching our patients who also had to be at home during lockdowns, quarantine, and isolation rooms. Thanks to technology, laptops, notebooks, tablets, cell phones, etc., and the internet. Second, we were able to create a blog called Payong Kapatid, or Employees Compensation. Employees who left their job in banks, telecoms, volunteered their services, and offered their technical skills in communication. This gave rise to a blog that did not limit our services to our hospitals, cities, and provinces, and mining industry alone, but expanded it nationwide. Through above blog, the Occupational Health and Industrial Medicine Department at Notre Dame de Charles Hospital have successfully served patients with disabilities in Cagayan de Oro in Mindanao, Bacolod and Iloilo in the Visayas, Leyte, Bicol, Antipolo, Cavite, Cagayan, and many other provinces from north to south. Medical tourism, on the third, became, because of the blogging, patients not only in the mining industry learned about their SSS and EC disability benefits. However, the wide gap between knowledge and practice in disability claims is so pronounced that some patients had to fly from Visayas to Baguio, 1,000 kilometers away, to get the expertise in compensation medicine. It's not just the advanced equipment such as CT scans, MRI, coronary angiogram, PCI, audiogram, and brain response audiometry, stress echocardiogram, etc. To complement medical tourism is the need to set up an Airbnb for competitive and quality accommodation, since some conditions are not admissible under Field Health and Social Security system. The OHIMD NDCH is linked with accredited accommodation and homestay within Baguio. Through above implemented innovations and best practices, I would say, we are able to extend timely, adequate, and meaningful occupational safety and health services with disability compensation, not only in the mining industry, but also beyond. Again, as we aim at a moving target toward continuous improvement, we, the responsible stakeholders, bring us to the evaluation of the innovation presented here for the next cycle, the planning session, completing the PIE cycle. By closely monitoring our employees and protecting them from workplace hazards, we are in the best position to deliver occupational safety and health in the mining industry and deliver just, timely, and meaningful compensation in case of accident, illness, and even death. A legal and moral obligation that balances the equitable distribution of the fruits of production between workers and employers, thereby achieving industrial peace and prosperity. In short, approximating our dream for healthy worker for economic work. Thank you so much for your kind attention and enriching engagement.
Thank you, Dr. Leo, for that informative talk on compensation. Indeed, occupational diseases and injuries are costly for both the industry and the nation as a whole. Health is equated with productivity, and productivity is equated with industrial profit and national revenues. Now let's proceed. Leigh McMaster is the current Vice President of ISA Mining Africa. He is an expert in the disciplines of industrial psychology, occupational health and safety, as well as risk management. He has worked on numerous projects and participated in task teams on occupational safety and health. To discuss the industry control management approach towards fatality elimination, let's hear from Leigh McMaster all the way from Africa.
Good morning, Chair, and thanks for the opportunity. I just want to quickly share the presentation. I trust it's visible. So, good morning, colleagues. Thanks very much for the opportunity. This morning I just want to share some insights in terms of risk and critical control management. It is something that we have been applying in this African mining industry for some time, and we've initially and traditionally applied this in the safety realm, but subsequently we have extended this to occupational health and occupational hygiene. So what you will see is one of the tools that's very active in our industry. So as you can see, on the screen, these are the occupational health and safety milestones for the South African mining industry. This is agreed on by tripartite stakeholders in the industry, meaning employers, government, and also the organized labor or trade unions. And here you can see we've got some milestones set down for elimination of fatalities and injuries. Then we have also the elimination of occupational diseases, and you can see there, I think this would be of keen interest to everyone on the call today, but you can see there we're targeting a 95% reduction of exposure and measurement results. And there you can see for respirable dust, specifically for silica dust, platinum dust, and coal dust, those targets set for those exposure limits. Then elimination of noise-induced hearing loss. So by December 2024, no equipment should emit noise exceeding 107 decibels. And a previous milestone in 2016 was already that there should be no STS threshold shift that will exceed 25 decibels from the baseline. Then also very importantly, reduction and prevention of TB, HIV and AIDS. And there you can also see the different milestones that are set, very important for us. And I think as an industry in South Africa, we are doing exceptionally well in that area. Just to say that this is really the framework that we use for critical control management and for risk management in the industry. And so you can see there that all companies in industry are really utilizing this process to ensure that their baseline, the issue-based, their task-based risk management, and their continuous risk management is requisite to preventing injuries and fatalities and health exposures. So this framework is used throughout all of these disciplines in health and safety. Maybe the one thing I just want to point out from the slide is the material unwanted events, identifying those. And you will see later on in the presentation the material unwanted event that we also identified for specifically health exposures. And then you can also see there one of the critical tools that we use in this process is the bow tie analysis. Again, historically used in safety, but more frequently now used in the occupational hygiene and health fraternity. And I will focus very much on the bow tie analysis and how we classify controls in the industry. So here's just a brief slide on the entire process. This process was developed by a multi-stakeholder and multidiscipline forum under the ICMM, but subsequently adopted in the South African mining industry. And this is just to illustrate to you the process we follow in identifying what our material unwanted events are for health, hygiene, safety, etc. Then how we identify the controls, selecting the critical controls, how do we determine the performance and reporting criteria, and also how we assign accountability and implement the process from there. This is the typical risk matrix. I think many people are quite familiar with. The one thing we often highlight, and we also, in terms of implementation of our work, we approach it in this manner, is to really, when you start looking at your weighting of consequence versus likelihood, we emphasize that the minute you have a high or major consequence, and this typically is a potential single fatality or multiple fatality, that event should be treated as a material unwanted event. So I think with many practitioners historically, we've typically looked at events where, for instance, we had a high or major consequence, but if the likelihood of this event occurring was rare, then it reduces that risk to a medium or significant risk. And then it often just slides off the view of many people and companies and industries. But certainly we emphasize that even in the event that you identify that your likelihood of that event occurring is quite rare, but the consequence is high or major, that should be treated as a material unwanted event. Just forwarding quickly to the aspect of controls. I know this is a very much a safety example, but this classification and definition of controls that we apply is equally applicable to the health and hygiene space. Traditionally, we've treated, when we looked at controls, I think many of us are familiar with the hierarchy of controls, and there were a number of controls that we clustered under administrative controls in that hierarchy that actually don't fit the classification and definition of a control. So a control can only be an object, a human act or system, as you can see on screen. An object is typically a physical structure or engineered device or object, whilst the human act is something that we do, and a system is a combination of acts and objects. And you can see by virtue of this example on screen, this is a typical example of a pedestrian crossing a road, a vehicle approaching the pedestrian, and that pedestrian either walking across a bridge or walking across the pedestrian crossing. This clearly illustrates to you, what that, how that control regime works. So, just going on to that as well, this is, once we've identified the control using that classification, we use this decision tree to identify whether a control is a critical control or not a critical control. So here's the typical decision tree that we follow for all of these decisions around the materiality of the control. And typically you can see here that the most important questions in this decision tree is whether the control is the only barrier, whether the control is effective for multiple risks or threats, and if the control is independent, and that would then deem the control to be a critical control. So this is just the bow tie analysis that we use. There's many other analysis tools that's been used historically. I think what we like about the bow tie as an industry is that it really puts visibility on the controls, what you need to manage to obviously ensure that your threats are managed on your left-hand side of your bow tie, and then on the right-hand side of your bow tie, your consequences. So on your left-hand side of your bow tie, you've got your preventative controls. On the right-hand side of the bow tie, your mitigating or recovery controls. So I spoke a little bit about the hierarchy of controls. Typically, this is the hierarchy that we use in the industry, but we found in stress testing controls, due to the according to the classification of controls, that our historically, as we knew them, administrative controls, procedure standards, training, induction, risk assessments, and typically pre-use checklists don't fit the classification of controls. So we don't apply those as controls in the industry at the moment anymore. So what do we do with these typically historically administrative controls? We acknowledge that these are control dependencies. So typically, this is how you apply it, a procedure that typically specifies and guides the UN Act. The standard is an object or system specification. The training equips people with operational task knowledge. Induction provides introductory knowledge and operating environment awareness. The risk assessment is merely one of the verification mechanisms to verify that controls are indeed in place. And then the pre-use checklist is the pre-work or task verification. That's often a list of objects and system controls that must be functional, whilst the pre-use check is also verification of control availability and functioning. So, as you can see, typically with all of these elements listed on the left, we historically treated those as controls, and those aren't controls. Those are merely control dependencies. So with that in mind, this is the more updated hierarchy of controls that we prefer to use. So very much similar to the traditional hierarchy of controls, apart from the fact that you don't see any administrative controls there, as we now treat those as control dependencies. Maybe just in finishing up, this is the very difficult to show in this type of format on a PowerPoint, but and I'm not expecting you to read this, but on the big diagram that you see there, that is the entire bow tie for occupational health and hygiene risks in the South African mining industry. This we developed over several months with all of the mining companies that are members of the Minerals Council. So it's about 74 mining companies that we've developed this. Here's just an extract of one of the threats, which you can see is not adopting the best workplace health and hygiene best practices. And then you can see there's just, how we detail the controls. So the development of the programs, the industry support, etc. And then all the activities or control dependencies list underneath. So what this gives us now as an African mining industry is visibility of the controls that we need to manage to obviously ensure that we achieve the milestones at the end of the day. Thank you, Chair. Thanks for your time.
Thank you so much, Lay. Indeed, the elimination of fatalities is dependent on the elimination of hazards. The use of personal protective equipment is only complementary to the overall systems control intervention as discussed by Lay, including administrative and engineering controls. So to eliminate occupational diseases, injuries, and disabilities and fatalities, then we have to eliminate occupational hazards. Our next speaker is from Canada. After university graduation, Bruce Cosgrove collaborated in the development, financing, deployment, and the commercialization of numerous state-of-the-art world's first technologies, which include the Moly Energy Limited, a rechargeable lithium battery technology, also another microchip technology used to monitor automobile onboard computer diagnostic systems, and another chip technology used to monitor oil and gas pipelines. For the past 7 years, Bruce focused on the replacement of mercury, a deadly neurotoxin used in ore processing, which recovers only 30% of the liberated gold in the ore, with the rest of the gold lost to tailings wastes. Today, Bruce is pleased to present a paper titled Environmental Remediation with Profitable Gold and Silver Production. Take note, Bruce is an artist, a serial entrepreneur, scientist, research chemist, all rolled into one. Let us all welcome Bruce Cosgrove.
Thanks, Jinky. Thanks for that great introduction. And yes, hello. I'm all about technology. Today I'll describe how Manipura, a cryogenic plant-based extract solution, commonly known as, I'm just sharing my screen. Bear with me here. Right here. Share here. Did I share it? No. Oh,
yes,
shit.
yes.
Is it sharing?
Yes, we see it.
Here.
Oh, you do? Okay, good.
Full screen.
Okay, full screen. Here we go. There we go. Everybody in?
Yes, perfect.
Great. Okay. Again, thanks for the introduction. Today, I'll describe how Manipura, a cryogenic plant-based extract solution commonly known as the cassava plant's toxic wastewater containing aqueous-free cyanide, when used as a lixiviant to recover precious metals from ore and tailings waste, equals environmentally sustainable profits. Greetings. Nice to be here. Thank you for the invite. Ore processing using mercury. The use of mercury in artisanal ore processing, as you've all discussed today, causes damage to the miner's nervous system, digestive system, immune system, lungs, thyroid, kidneys, causing memory loss, insomnia, tremors, neuromuscular changes, and paralysis. Based on scientific studies, there's approximately 20 million artisanal miners in 80 countries around the world, all largely suffering from undiagnosed mercury poisoning, including 4.5 million women, 600,000 children, all due to the mercury use. Miners accept these symptoms as the aging process. In perspective, artisanal miners who process less than 2 tons of ore per day typically earn $4 to $5 US and support a family of 5. Whole ore mercury amalgamation Chilean processing centers and artisanal miners' use of mercury in ore processing is the planet's largest anthropogenic source of local biodiversity destruction, human health threats, and deadly global atmospheric pollution. Atmospheric pollution is documented in 2021 to stay airborne up to 1 year. Compared to artisanal miners' ore processing centers make the majority of money generated in the industry and globally produce 18% of the world's gold supply using art jewelry, iPads, iPhones, computers, and other e-devices. Collectively, they are responsible for the annual release and discharge of 2,000 tons of mercury to our environment, not the wrongly accused artisanal miners who only produce 2% of the artisanal gold supply. The target here are the ore processing centers. Mercury is a deadly neurotoxin, which we all know, and it's used as a lixiviant to recover gold. Chancho barrel ore processing is the planet's largest anthropogenic source of deadly land and water mercury pollution. The artisanal miners add 100 times more mercury than the required amount of mercury to the Chancho barrel to amalgamate the gold in the slurry and still lose 70% of the gold. Why? Mercury only amalgamates with liberated gold, not exposed gold. Exposed gold can be leached. All the exposed gold in mercury amalgamation is lost to tailings waste. Now we've talked about Indonesia, some of the scientists here in the Philippines. I had actually spent about a virtual year in there looking at the borax flux smelting, which was developed in the island of Luzon. But in talking about tailings waste, we'll just take a look what's in Indonesia. For example, 9.54 parts per million is 9.54 grams per ton. In the Philippines, 16.5 grams per ton of gold is lost in tailings waste. That's more gold than a lot of the miners mine in their mines. Mercury flour is created when the mercury-bearing gold has been pummeled into the Chancho barrel such that it becomes so small in diameter, the surface tension is too high to coalesce, leaving renegade gold-bearing mercury flour lost to tailings waste. Uganda's solution. Uganda, cassava, is Uganda's second most important food crop with an annual production of 3 million tons since 2013. We propose to use a solution extracted from plants, bitter cassava, as a gold leaching lixiviant to safely recover more gold from ore and sustainably than by using mercury. The use of manna pura as a lixiviant was conceived by Dr. Marcello Vega, professional engineer, professor emeritus, University of British Columbia, Canada, who, together with Paria Torgman, a UBC PhD graduate student and researcher, developed the leaching process protocol. What is manna pura? Manna pura is a cyanogen solution extracted from the bitter cassava plant. Aqueous-free cyanide is produced when the integrity of the plant's cellular structure is compromised, causing the enzymatic hydrolysis of the linamarin when exposed to linamaris, an enzyme normally expressed in the cell walls of the cassava plant. There you can see the chemical reaction right there. Manna pura, nature's lixiviant, safely leaches more gold from ore and sustainably than by using mercury, a deadly neurotoxin and the precursor to methyl mercury at 100 times more potent and with unknown bioaccumulation effects. During the manna leaching process, which employs a modified version of the Merrill-Crowe process, all the free cyanide is consumed, resulting in gold recovery in excess of 95%. Today, 270 million tons of the bitter cassava plant are harvested annually, and the manna pura solution is recklessly disposed of by flour manufacturers, polluting the soils. The aqueous-free cyanide solution has a pH of 3.5, weighs up to 3.35% of the plant's weight, and contains 267 milligrams of cyanide per liter of solution. How do you make this work successfully? Cyanide? Manna pura can replace the use of mercury in whole ore Chancho barrel processing. The mercury is stabilized in the tailings pond prior to transfer to the leaching center. The symbiosis of artisanal ore processors and flour makers is a win-win situation to reduce environmental pollution, human health threats, and mitigating an unintended consequence of harvesting the bitter cassava plant. This is a manna pura leaching circuit overview. After 2 rounds of research and development undertaken at the Norma B. Keevil Chairman Emeritus Institute of Mining Engineering, UBC, spearheaded by Marcello, the company advisor, enable the design of the world's first sustainable Manipur precious metals leaching center for processing ore and tailings wastes. We've coupled Chilean mills to increase productivity with state-of-the-art centrifuge that recovers, what's my cursor? That recovers fine gold down to 400 mesh or 37 microns at 120 to 150 Gs acceleration. That's state-of-the-art. And what I'd like to do here is actually show you as part of it. This is a Gemini gold upgrade table compared to different shaker tables. This table shakes, but it rocks and rolls as well. It shakes and the heavy metals move down to the end of the table and water washes away the light stuff. And if you'll bear with me for about 30 seconds, I'll show you exactly how it's worked. I don't know if people have seen this, but it's way better than shaking tables, which is commonly used, which only recovers 60 to 65% of the gold because the rifts in the side are not designed the way this is designed. Can you see the video?
Oh, Bruce, you have to. Oh, yeah.
Did you see the video?
Yes.
Okay. See all the gold. This is tailings remediation. So the water washes all the light stuff away, and now you see the gold all accumulated inside. You empty it out. This is proven to recover about 97% of the gold. It's the state of the art. Now, if I can just get out of this window here. Screen's here, just 1 second. I've lost my share, but I think oh, here we go. All right, I'm back. Here's the overview. Continue. We've used Floth flotation. We use a modified version of the Merrill-Crowe process. The pH comes out of the Manipur at 3.5. We add sodium hydroxide to take it up, stabilize it at 10.5, prevents the emission of cyanide gas, which is one of the problems in leaching that is commonly used because the artisanal miners or the processors, when they do that, use the leaching. If they can't spell the cyanide, they don't think it's working. Manipur is nature's solution for artisanal miners and ore processing center owners to recover more gold and silver without human health threats or biodiversity destruction, utilizing a natural resource. Thank you.
Thank you very much, Bruce, for that wonderful research and development project that you have discussed with us. And we say it is a research and development project with a heart because you try to eliminate exposure of miners and community dwellers to toxic chemicals arising from mining.
Yes.
Now we proceed to our last speaker, Christian Moraga.
Thank
He
you.
is currently the Vice President of ISA Mining Chile and a development advisor in the Institute for an Industrial Safety Culture, an industrial engineer by profession who obtained his Master of Management and worked in the Chilean Social Security System as the Chief Executive Officer for the last 20 years. He promotes safety at workplaces and provides economics and health benefits to workers who have suffered from accidents. An advocate of safety culture, let us all welcome Dr. Christian Moraga.
Good morning. Thank you to the organization for inviting me to this important conference. It's an honor to me to be part of this panel with these global experts. I am Christian Moraga, Development Advisor of ICSI, the Institute for an Industrial Safety Culture. I am also Vice President in Mining Section of ISA. My presentation will be about the important role of leadership in the process of creation and development for in safety culture. This is the agenda of my presentation. First, I will talk a little bit about my country and the challenges for mining sector. Then I will give some information about my organization, ICSI, After that, I will talk about ICSI safety culture model and the critical role of culture in any safety strategy. Following, I am going to explain the role of managers and leadership in the construction of a strong safety culture, and finally, some conclusions about these topics. Chile is a long and thin country in South America on the Pacific coast. Our economy is based on natural resources. For sure, mining is very important in our economy. It's the strongest pillar in Chile's economy and social development. Is also a world-class industry. Mining also has been leader in introduce high standards for health and safety, not just for mining operation. This high standard for health and safety has been transmitted to all other economic activities. The challenges for mining sector probably are quite similar than we can find in other countries. It is important to create a better relationship with communities, develop human capital with the necessary competences to do an efficient work, and at the same time, engage with mining is also critical. Our specific geological conditions where mining operates in Chile create big issues for health and safety, as high altitude over 4,000 meters above sea level, solar radiation, long distance from cities and others. The way how mining operations use water and energy is also very important in our country. For sure, cost pressure and the need to keep competitive is a big issue in all our mining companies. Safety and promote safety culture is a main piece of the operational and business strategy in Chilean companies. And promote safety culture is a key to improve not just prevention, all the business performance, because safety cultures provides a lot of benefits. First, less accident. When you decrease the number of accidents, you can see and you can react cost savings with also quality improvement, because quality and cost savings go together. At the same time, you can improve your sustainability and the human capital development. Related with ICSI, ICSI is a not-profit organization based in Toulouse, France, with global activities. One of the main objectives is to improve safety in business, to promote safety culture at company level, at countries level, to avoid industrial accidents. ICSI is an association where participate different kind of organizations like education, research institute, trade unions, association, regional authorities, and companies and industries. All members share a common goal: develop and promote knowledge in safety culture to avoid big accidents. These are our members, more than 80 organizations from different economic activities, mainly in high-risk industries like airlines, oil and gas, construction, energy, and many others. The ICSI safety culture model have been developed with the experience of many high-risk industry. All these activities are like airlines, oil and gas, and energy are in extreme risk environments. They had had a big accidents, but most days these companies are safer than many other activities. In ICSI, we have structured the findings and conclusions of big accident investigation that have provided important learnings to how it is possible to avoid these situations. As I said, most days these high-risk activities work without accidents, so there is a rich knowledge base in everyday activities. How these companies with normal people can do risk activities without accidents. In this way, we can learn from everyday information about how to prevent accidents. Safety culture is the stronger strategy to avoid accidents, but at the same time, words like safety culture could be ambiguous and hard to define. It is important to have a clear model about safety culture with practical approach to implement activities in different companies. There are two classical approaches when we think in safety. One is the linear model. In this model, the focus is human error. Accidents happens because someone make a mistake. If you investigate an accident, your mission is to find who made the error, to define a guilty. With this model, to prevent accident, that is necessary to change people behavior. And to do this, the classic strategies are training, communication, and change behavior programs. The other model is the systematic model. In this model, the focus is the context. In this model, we assume that people make mistakes, and it is necessary to have a strong process and context to avoid accident despite the human error. With this model, to prevent accident, there is necessary work on the context, the process, the organizational decisions, technical barriers, and many other sources of prevention and risk control. In this approach, we assume that people make mistakes, but the organizational culture is enough strong to avoid accident and its consequences. Linear model is also known as domino model, and systemic model is also known as Swiss cheese model based on James Reason's publications. So, what is safety culture? How can we define safety culture? Well, in ICSI, we have a definition for this concept. Safety culture is a set of beliefs and values and behaviors. It's a way of act and think shared by all the members of the organization. The managers and workers share the same visions, the same values, the same behaviors. Is a shared belief also about how to control the main risk, and safety culture reflects the role of the safety in the organizational culture. This is a very good example about how the context affects people behavior. People will be like to leave their trash on the dirty beach than the clean one. The context shapes the behavior. In the same way, in safety, we must create workplaces where people, since the first moment, receive different signals about the role of prevention. For example, clean spaces, everyone moving according to safety standards, safety equipment, time in meetings, budgets for preventions, and many more. In these workplaces will be clear to everyone that safety is a priority. Everyone think and move, taking prevention as everyday standard. In this way, a new one worker will adopt this behavior faster, and it will be easy to see when someone is moving away from this safety standard to correct him or her. In this way, the role of leadership is critical to develop safety culture. Its leaders have an important role in create and craft the culture. And as I said before, it's the culture what improves safety. Leaders must define the vision, the strategic goals about safety, then share this vision with the whole organization. Then leader must assign the necessary resources and time continuous improvement, and the leader must involve everyone to build a teamwork for safety. To have a good safety culture, the role of leaders is critical, and also we need workers' participation and its commitment. Uh, Finally, safety culture is a key to keep improve OSH. The context define the behavior. Leaders and workers are fundamental stakeholders to build safety cultures, and managers has the responsibility to lead this process. This is our website where you can find different collection and resources with free access. Again, thank you very much for inviting me and congratulations for this conference.
Thank you, Christian. Indeed, we should not only change the behavior towards safety, but make a culture of safety. Because once it becomes a safety culture, it is part of the everyday life of the worker, and it is a recurring behavior. Thank you. Now, the floor is open for the question and answer. Our moderators are Dr. Ana Fajardo and Dr. Liam Genfuk. Ana, from the Philippines, is the current president of the Philippine College of Occupational Medicine, which is a specialty society of the Philippine Medical Association under the division of the Philippine Academy of Family Physicians. She is also an affiliate member of the International Commission on Occupational Health and Asian Association of Occupational Health, and accredited by the Philippine Health Insurance Corporation, the Department of Labor and Employment, and Professional Regulatory Commission. Dr. Jenriam Phuc is from Indonesia, a medical doctor, a PhD in occupational medicine, and a faculty from the University of Indonesia. He is a researcher and an expert on occupational medicine.
Thank you, Dr. Jinky, for the kind introduction. Hi, Dr. Liam.
Hi, Dr. Ria. Thank you.
All right. So this afternoon, we have listened to several of our experts all over the world, not just in the Philippines. And we hope that today's lectures have been an enlightening, have given all of us enlightening perspectives with regards to occupational health and safety in the mining industry. So we start with our first question, Dr. Liam.
Yeah, I noticed there's some question here, but I will read one. The first question is for Dr. Leo. I will read it. Dr. Leo, what percentage of the worker population in the Philippines is aware of their disability compensation benefits? Dr. Leo is with us right now. Yeah, Dr. Leo.
Yeah, I think he has internet connectivity issues, so may please
there.
proceed.
He's here. He's here actually.
He's there. Dr. Leo,
You're
kindly
muted.
unmute.
Okay, I'm sorry, I missed the question. Can I have it again, please?
Yeah, I will read it again. What percentage of the worker population in the Philippines is aware of their disability compensation benefits?
All right, no, thank you for that question, Jem. Very relevant. Actually, the social security system, the employees' compensation, and the Department of Labor have an educational program to, in an effort to inform all workers. It's also part of the orientation of every employees. However, once they get involved in the company and engrossed with work, sometimes this is forgotten. So I had a random survey, and it turns out only about 20% of registered employees are aware of their benefits, social security and employees' compensation benefits. And so I would really recommend a study, a formal study, so that we'll be able to implement the program adequately and more meaningfully.
Okay, thank you, Dr. Leo. May I continue with one more question regarding this answer? that yes, indeed, the compensation is an important factor for our mining workers, right?
Yes, of course.
Since you say that only 20% of them are aware about the disability compensation benefit, do you think those 20% are properly compensated?
When they come to our clinic, because by word of mouth, miners and other employees get to know our occupational health and industrial medicine that is involved with successful claims in compensation. They come to us, and we try to employ all the possible medical ways to be able to document. Of course, we go into their history and physical examination. We normally get them admitted. But as a rule of thumb, when an employee, especially minors, have reached about 15 or 20 years of work, we would already expect that somewhere and somehow they would have a work-related illness. And so we get them admitted and do a general exam. We look into the hazards of the workplace, like in the mining industry. Of course, we start with the ears. We do an audiometry. We do a stress test to look into the cardiac functioning, because we know that underground mining, they don't have adequate oxygen supply. So sometimes they get injuries because of poor oxygen or inadequate oxygenation. We do a CT scan of the joints involved, like lumbosacral vertebrae. And so we look into the hazards in the workplace depending on their assignment. And then we look into how those hazards would affect health. And we document them. And once documented, we have a very good average success rate. I would put our success rate from 85 to 95% once they're fully documented. And then we get, of course, we need their certificate of employment, job description, and accident report when it's available.
Okay, thank you.
Thank you. Right. Thank you, Dr. Leo. And I see another question here for Dr. Karen Rimando. Dr. Karen, you've really given us a lot of insights and inputs with regards to the health and safety program for our mining industry. And do you think people are aware enough of these policies and programs, and what do you suggest regarding its implementation? Kindly unmute, Dr. Karen.
I'm sorry. Doctor, in the company where I am affiliated, we make sure that the employees are aware with the policies and the programs. We work in coordination with the safety department and the human resource department. So we conduct IECs during their meetings or on pep talks, or we also share them we also conduct our quarterly safety and health hour, so for the concerns of employees, and then we inject these kinds of topics in these kinds of meetings or activities.
Thank you, Dr. Karen. And I heard about the part about informing them on a quarterly basis, no? Especially in hazardous workplaces. I think that's very important, and that's a standard, no, for our DOLE. So thank you very much, Dr. Karen. Dr. Lien, are there any other questions?
Yeah, we have a question here for Bruce, I guess. Bruce, are you with us?
I'm here. There you are.
Okay. Okay, Bruce, I will read a question for you. How successful so far is the accommodation of the technological innovation and alternative technology in small-scale mining? Of course, this depends on your experience, maybe. Please share with us. Thank you.
So let me understand the question. You're asking what has been developed thus far? And is it for artisanal miners or for large scale miners?
Yeah, in a small scale mining.
Okay.
Actually, do you have that experience?
Yeah, well, right now, based on the research at UBC, which I'd mentioned, spearheaded by Marcello, over the course of several years, they, along with a company called Nulocks Gold Ventures, which is I'd mentioned in there, in the presentation, had kind of commissioned with the university and developed this reprocessing center for tailings. And they had, and they were getting 95%, and they were using cassava, Manipura, the extract. And so they built a small 80 tons per day plant, but they'd had that for a long time in Costa Rica. But when they developed it, so it was more of a reprocessing plant for tailings only, it's become very successful, and they're building one in Brazil as well. So we're looking to implement ours in the Portobello Zaruma mining district, actually in Zaruma, which is in Ecuador, one of Ecuador's 5 UNESCO World Heritage Sites and the pinnacle source of global mercury pollution. So we've been working up there with a geologist, and over the past couple of years now, to do a joint venture to convert a Chilean processing center to mercury-free processing using ours. And that processing center that you saw in the diagram, all those video links are live to show you each and every process. That's an 80 tons per day facility. That'll produce, we figure, about 9 to 10 kilograms of gold per month versus the 6 they produce right now.
Wow,
Yeah.
wow, great. Thank you,
Yeah.
thank you, Bruce. Yeah, back to you, Dr. Ria.
Welcome. Yeah.
All right. Okay, thank you. Thank you, Bruce.
Thank you.
Maybe we'd like to ask a question for, all right, for Dr. Lay. All right. Okay. I think Dr. Nga has an urgent concern. Dr. Alex, are you with us, Dr. Alex?
Yes, Dr. Ria.
Hi.
Good morning.
Good morning. Dr. Alex, I have a question here for you. So do we have existing programs in the Philippines to support the early detection or testing for our miners? Is this covered by PhilHealth, no? The government health insurance here in the Philippines?
Dr. Ra, as of the moment, yes, it is covered by PhilHealth. But again, the coverage would be a condition case coverage, whereby you should have already the disease before they cover it.
Okay. All right. So that means, and that's very good news that PhilHealth is covering these diseases, right? It's very good news for us, for the Philippines. So,
Dr. Ra, but probably what we would like to happen would be the blood lead monitoring would be part of the PhilHealth coverage. The monitoring itself during surveillance should be part of the PhilHealth coverage or the medical coverage.
right. That's a very very important concern, no? Because you want to know that lead is one of the important blood tests that need to be taken for our miners. So thank you, Dr. Alex. Thank you for your answer. Dr. Liam, I don't seem to have any more questions. I don't
I have
see
a
any more
question.
questions.
I have
Yeah,
a
there's
question
no more.
for
Oh,
Dr. Lay and Dr. Christian. I sent it to you, Liam. Can you read it?
Dr. Mr. Lee McMaster was not here. Also, Dr. Nga,
Okay,
he
okay.
left.
Okay.
Okay. Yeah, back to you, Dr. Ria.
All right.
Okay,
Okay.
so thank you so much,
Thank you.
Dr. Ria and Dr. Liam, for that question and answer portion. Thank you also for your support. Thank you to all our speakers. Later, we will shift to the Zoom link in our Kampala conference. And before I proceed to my closing remarks, can we have a group photo, please?
Yeah.
Sure.
Can you count? Can you make a, a signal?
Okay. Then one, I will count, yeah? 1, 2, and 3. Okay, one more time. One more time, sorry. Wait a moment. I will take off my mask. Wait a moment. Okay, 1, 2, and 3. Okay, got it.
Okay, thank you
Thank
so
you.
much.
Thank
And
you.
now our
Thank
virtual
you.
platform has come to a conclusion. On behalf of Minosh, thank you for all your participation and the sharing of your researches and advocacies and best practices from your respective countries and how to move forward. Hearing and learning from all our speakers, the third international conference in Minosh indeed was able to serve its purpose of gathering us all together and keeping us updated on the issues surrounding occupational safety and health, including environmental health in the mining industry, both small and large scale in a rapidly changing world. What are the important takeaways in this virtual session of ours? I would like to align it with the vision mission of Minosh. First, our researches and advocacies should be multisectoral, involving the large, the middle, and small-scale industries and their mining workers. Second, our researches and advocacies should be multidisciplinary, cross-cutting disciplines in medicine, occupational health, allied health, industrial hygiene, engineering, social science, policy, economics, technology, development, and chemistry. Third, our researches and advocacies should be multi-level, both country-specific and international in nature, as what is being done by ICO-Minosh. Last but not the least, our researches and advocacies should be multi-strategic, covering research, advocacy, extension work, and program policy orientedness. All our speakers have acknowledged that there are still issues in occupational safety and health that need to be addressed, and evidence-based strategies that we can support, adapt, and promote are there. Okay, and now we are also encouraged to become advocates of safety culture in mining. After all the presentations, there are still a lot of work ahead of us. Many issues and questions that need to be raised for further discussion and research, programs and advocacies that must be supported and promoted. However, we cannot do all this within one day. We will need to meet again and include this in our future endeavors. For now, may all that was shared in our virtual conference help us in promoting and advocating OSH in the mining sector towards decent workplace and the national global health for all.
Thank you.
Thank you so much.
Thank you, everyone.
Thank you.
Thank you, everyone.
And before you go,